cardiac emergencies. You should be taking notes this time. There's going to be a bunch of stuff in there. You're going to be underlining. So I told you this presentation, how many does it say?
94.
Yeah, I'm taking out about 40 or 45. So, but I will tell you that there's material that will be in this presentation that's not in your textbook. So hopefully you've read your book so you know what's in there, so you'll be able to recognize the things that are new, right? If you don't know the difference, then you'll just be scrambling and writing down everything, right?
Yes.
Okay. This will be posted so you can go back and refer to it, but there will be material here that you do need to know that is not in your book. So, y'all ready? We're going to be looking at acute coronary syndrome. That's going to be the umbrella term for anybody having problems with their heart. We're going to look at the conditions that can lead to a cardiac emergency. We're going to look at cardiac arrest and the chain of survival. We're looking at AEDs in here. Does that sound like something we've already been over? Yeah, so we'll breeze through some of that kind of stuff. We're going to look at management for a patient in cardiac arrest as well as patients with acute coronary syndrome. And we'll just look briefly at CPR devices. But that part of it we've pretty much been over except the devices. You can just read about that. But we are going to be looking specifically at different disease processes and types of patients that you'll see that have cardiac issues. That's mainly what we're going to be focusing on. We've already looked at the heart, the anatomy and physiology, but we're going to touch on that again so that you can understand it in light of the different problems that you'll have with our cardiac patients. Okay. The heart. You will need to be very familiar with the heart, the way the blood flows. Remember the three parts we talked about? The pump, the pipes, and the fluid. We're talking about a motor. What's the pump? The heart itself. The pipes, the circulatory system. And then the fluid is the blood. And remember, all of those parts have to be working in conjunction for the heart to work well. We're going to be looking at blood flow through the heart. We're going to be looking at what happens when we have tissue death or ischemia. Ischemia actually means you have a blockage of oxygen or no perfusion to part of the heart muscle, and so it's suffering because it doesn't have enough oxygen. That's going to be ischemia. Make sure you know all these terms. We've been over them before. What is the valve on the right side of the heart? What's that called? Is that right? Tricuspid valve. What's the one on the left? The bicuspid or the mitral, or the mitral valve, right? The vessel that brings blood back from the lungs to the heart is what vessel is that? Why is it the pulmonary vein? All veins return blood to the heart. So is that blood oxygenated or deoxygenated? It's oxygenated because it's coming from the lungs to the heart. Okay, the pulmonary vein then returns blood to what chamber? The left atrium, because all blood returns to the heart into one of the atria, and all blood leaves the heart from what chamber? The ventricles, if that helps you remember. Okay, what are the major vessels that return blood to the heart from the body? The superior and inferior vena cava, that's right. And what's the vessel that takes blood away from the heart? The aorta, primarily. What is the vessel or vessels that provide the blood flow and oxygen to the heart muscle itself? The coronary arteries, okay. They get first blood. For those of you that have trouble with this, the blood comes into the right atrium and then it flows through what? The tricuspid valve into the right ventricle. From the right ventricle it leaves via what vessels? The pulmonary arteries, because it's moving away from the heart, and it goes to what? The lungs. From the lungs it returns via pulmonary veins to what chamber? The left atrium. And from the left atrium through the bicuspid or the mitral valve into the left ventricle, and then it leaves the heart via the aorta. That's correct. Okay. You need to know that. All right, y'all ready? I think that's what that star means. Blood pumped from the lungs is pumped to the, why is that thing up top? Polling's open, so let's hear it, guys. Okay, what's the deal? Oh. I guess Poland closed, huh? Well, the left atrium. Blood from the lungs is pumped to the left atrium. Some of you put the right atrium. The right atrium gets blood from where? From the body, that's right. Okay. Okay, we talked about cardiac output. Cardiac output represents what? Who can tell me what cardiac output represents? You can probably read it. Is what? The pumping of the heart, but it's really the volume and the energy that goes with the blood as it exits the heart. So that's going to be cardiac output. The amount of blood that exits the heart, and then the pressure under which it exits. So if that pump is not able to pump, if the heart's not able to pump, we're not going to have any cardiac output, right? What else could interfere with cardiac output? What? Yeah, but what specific part of heart attack? Okay, if you have left ventricle failure because of ischemia, it's not able to pump. What else can interfere with cardiac output? So electrical issues, yes. If the heart's not getting the electrical impulse for it to contract, what else? Okay, I've been shot and I'm bleeding out all over. Well, yeah, if I'm not getting enough fluid into the heart, I can't get fluid out of the heart. So there are several different components to cardiac output. So for any patient that looks like they're really sick, they're having a cardiac issue, it could be an electrical issue, it could be a mechanical issue, it could be a fluid issue. So it could be a lot of things involved with that. Now remember the cardiac conduction system. We've got three pacemakers. What's the main pacemaker of the heart? The SA node. What's that stand for? Sinoatrial node. And if you see, it's located high in the right atrium, right up here. So what's its normal default rate? 60 to 80. Close. 60 to 100. That's going to be within normal limits. That's also going to be a normal pulse rate, right? 60 to 100 is a normal pulse rate. So this is what you wanted to pulse at. If it fails, its first backup is going to be the AV node. What's that stand for? Atrioventricular node. What's its default rate? 40 to 60. So if the top one, the SA node fails, then our next in line is going to be the AV node, and its default is 40 to 60. And if that fails, what's our last one? The bundle of His, that's right. And it's located right through here, and it's going to send the message through the Purkinje fibers. What's its default rate? 20 to 40. Okay. Now there's a lot more complexity to this than we're going to go over in here, but if you go on through the program, we'll spend a lot of time on this. So we got a star here, so that means there's something good coming. I actually put these together last semester, and I realized one of the mistakes I made is I gave you the information, then I asked you about it. It's like, duh, I got that, right? So subsequent ones, you notice I've asked you beforehand. The bundle of His has a default rate of, if you'll miss this, we're really in trouble. How can I have 14? Oh, we do have 14. Yay! Extra points for you guys.
Oh, please.
Gave you an easy one.
Please do that.
Please, extra points. How does the normal function of the heart and blood vessels relate to the blood pressure and distal pulses? How about if the heart's not functioning right? If it can't get a good contraction, then we're not going to get blood pressure, we're not going to get distal pulses. All that talks to the components of the heart, that everything has to work together. How is shock related to the function of the heart and the vessels?
Because they're not working.
Yeah, if the heart's not working properly, it's not going to get the fluid around. It's not going to be strong enough. We're not going to have cardiac output. A decrease in cardiac output, a measurable, sizable decrease in cardiac output will put your patient into shock, right? And it doesn't have to be because of hypovolemia. It doesn't have to be because we've lost a lot of blood. If the heart's not able to pump hard enough to pump it around, are they going to be shocky? Sure. What kind of shock do we call that? Yeah, cardiogenic, if the heart's not able to do its work. That's right. Okay, let's look at acute coronary syndrome. Now, you'll see that shortened, they'll say ACS sometimes. So acute coronary syndrome doesn't necessarily mean a heart attack, but it means there's something going on with the heart that's a problem. Cardiac compromise is another term that you'll see. Anytime the heart's not getting enough oxygen, then we're going to call that acute coronary syndrome, regardless of the cause. It could be caused by something other than a heart attack. Can you think of anything that could cause the heart not to be getting enough oxygen? Do what? Any obstructed airway, any kind of hypoxia, hypovolemia, anything that could interfere with the heart getting oxygen. Sometimes you can have patients that have other signs and symptoms that don't relate specifically to cardiac. And we'll talk about some of those a little bit later. If you have any patient that has signs and symptoms that look like they're having a heart attack, you're going to treat them like that until you find out otherwise. This little thing just talks about the difference between angina and MI. AMI or MI, or you'll hear those used to mean a myocardial infarction. That's really a weird phrase. Don't you think? Myocardial infarction. Infarction, as I said a minute ago, means what? Well, I didn't say, actually I was talking about ischemia, right? Ischemia means there's a blockage. Infarction, we have tissue death. Those are two terms you need to be familiar with. Ischemia means there's something interfering with oxygen reaching the tissue. So the tissue is hypoxic. For it to be infarcted, that means there's tissue death. Spell what? The what? Ischemia? I'll write it. Thank you for asking. Ischemia, or ischemic. We'll say that tissue is ischemic.
What does that mean?
It means that there is there's no oxygen to the tissue. The tissue is hypoxic. And if you don't clear up that ischemia in the heart, it's going to infarct. That means the tissue's going to die. So it's kind of like, I mean, you can close off blood flow to your finger for a while, and after a little bit, it's going to start turning blue, and it's going to be ischemic because it's not getting enough oxygen. If you hold it there like a tourniquet, it's going to infarct. Does that make sense? Now, I think, let me look here real quick and go back. Okay. I'm going to have to move the slide around. We're going to talk about the difference between angina and MI. Who knows what angina is? You have that too?
Actually, I used to, yes.
Okay.
I hadn't had it in a while.
That's good. What is it?
Oh my gosh, I get so much pain. You know, I was like knocking it in the face.
Did I mention something?
Not really. No.
Prince metal, probably. Does that sound familiar? No. Okay. Some of the differences between angina and an MI, angina goes away. It's temporary. It is ischemia. It is not infarction. So a patient with angina, they have a temporary blockage, usually due to increased demand on the heart. Like somebody that has angina, they're out mowing the lawn, and their heart's requiring more oxygen and more blood flow than the heart can provide. Usually that's because the vessels are constricted. It could be due to plaque or buildup in there. But to angina? Probably not. So with angina, the vessel is constricted for whatever reason, and there's not enough diameter to carry enough blood flow and oxygen to the heart. So they start having chest pain. That doesn't mean there's an infarction, it's just a decrease in oxygen to the tissue. So it's usually temporary. It usually goes away once the patient rests. That's going to be the key. If your patient says they had chest pain while they were laying in the chair, you know, changing the channels with the remote, does that sound like angina? No, because I told you that it causes an increased demand on the heart. So I'm talking about stress, or they've worked too hard. You know, somebody that has a lot of plaque and cholesterol build up in their vessels in the coronary arteries, if they go out and try to run 5 miles, they're going to have severe chest pain because their heart can't keep up because the vessels are constricted for whatever reason. But as soon as they rest and put their feet up, you know, and have a cold drink and relax, then their chest pain usually goes away. So that's going to be the main differences between angina and AMI as far as presentation. The signs and symptoms are going to present the same. They may say they have substernal chest pain. They may say it's pressure on the chest. They may be diaphoretic. Remember what diaphoresis is? That's where you're sweaty, but it's not because it's hot outside or humid. They may report they have pain in their jaw, in their arm. It could be either arm. More commonly we hear the left arm, but it could be either arm. They could have pain in the back. Women in particular report back pain more commonly than they report substernal chest pain. So for a woman, we call that atypical, but it's really more typical for women. So they may report back pain. With angina, the key is the duration. It usually lasts between 2 and 15 minutes, and it subsides after the activity stops. So they're not having a heart attack. They're just putting too much stress on the heart, and the heart can't be perfused well. Whereas if they're actually having a heart attack, usually their activity level doesn't really matter. It just as frequently comes on while they're exerting as it does when they're not. You know, you hear about people that are out running a marathon and they have a heart attack. I mean, anytime they run a race, there's usually 2 or 3 people that go down with some type of heart problem. Well, I mean, you can have a heart attack anytime during a 24-hour period, no matter what you're doing. It's not necessarily tied to the fact that you're out there running. It could have happened if you were home laying up in the easy chair. So sometimes it happens then, but oftentimes it's not related. Which one of these patients will we give nitroglycerin to? Yeah, we'll give it to both of them, absolutely. Nitroglycerin will usually clear this up for the patient with angina because it dilates those coronary arteries. That's the action of nitro, remember? It dilates the coronary arteries. So when that happens, then it allows more blood flow, so it's going to reduce the pain because they're getting enough oxygen there. With somebody having a heart attack, it doesn't go away after 10 minutes. Occasionally you'll hear of a patient that says they've had some chest pain for, since the day before for several hours, and it's usually pretty constant. If they've had chest pain for some length of time and they haven't died yet, that's always a really good sign. Half of heart attacks where the patient actually dies, they die within 2 hours of onset of symptoms. So that's pretty quick. So the majority of them actually die within the first 2 hours of onset of symptoms. So if they've made it a number of hours, that's good for them. So anybody that's having chest pain, they need to call 911. Have y'all ever known of anybody having chest pain and grandma or somebody's put them in the car and drove them to the ER? You ever heard of that? Mm-hmm. Yeah, that is crazy. In fact, we had a paramedic that you may or may not meet in the course of your time here who was having chest pain, and he knew, he was a paramedic. His daughter was in my class, and they put him in the car and drove him to the hospital. He was just so lucky. But anyway, if somebody's having a heart attack, if they're having chest pain, you need to call 911. because they're going to have things, they're going to have AEDs, they're going to have defibrillators, they're going to have medications, they're going to have oxygen. Just about anything they can do promptly in the ER, they're going to be able to do in the ambulance. And I can tell you, I've worked my share of cardiac arrest where grandma's put him in the car and they're driving him to the hospital. And all of a sudden his eyes roll back and he falls over and grandma doesn't know what to do. So we're working a cardiac arrest on the side of the road or in the parking lot at the hospital because they did that. So if it's anybody you know or a family member, call 911, right? We'll go over this more as we go through. Signs and symptoms. Chest pain is going to be the most common sign of a heart attack. They will report chest pain. But there's a lot of atypical signs and symptoms, and there are also a small subset of patients that feel no pain at all. They're just dead right there, pretty much. They'll usually say it is a dull, crushing, squeezing pain. Usually you're not going to hear a sharp pain. Can they say it's a sharp pain and they've had a heart attack? Yes. But most commonly, they're going to say it's dull, heavy, squeezing, that type of pain. Pressure or discomfort is something that they'll say. It often will radiate. It'll go up into the jaw. I've had patients say it feels like a toothache. Pain down into the arm, the back. Sometimes they'll say it feels like indigestion. In fact, that's probably the most common reason that people don't seek care. They'll say, well, it seemed like it was indigestion. So indigestion is going to be a sign or symptom. If you have a patient that says, I just have really bad indigestion, you're going to think cardiac, even though that's an abdominal kind of thing. Dyspnea. Remember dyspnea? Dyspnea is difficulty breathing. That also is a sign of acute coronary syndrome. Shortness of breath, difficulty breathing. It may be the only finding in some patients. So you may have patients that don't have any chest pain. It's just respiratory distress. Why would they have respiratory distress? The heart's not working right. Cardiac output is dropped, so you're not getting enough oxygen to the body, to the cells. What's the response to the body? What does the body do when it's not getting enough oxygen? Increases their respiratory rate. So the patient may not feel like they're getting enough air. It goes beyond just increasing their respiratory rate. They feel like they're suffocating. One thing that we see commonly too is patients will report a feeling of impending doom. They become very anxious. Why are they anxious? Altered mental status due to hypoxia. I mentioned that earlier in the semester. They're not getting enough oxygen. It makes them anxious. Same thing when I mentioned about a head injury. A patient's got a head injury, they get very anxious and combative because their brain is not being perfused well. Nausea is also a common symptom of heart attack. Why is that? Nausea and vomiting. Yep. When you've got a decrease in perfusion, that's one of the first things the body shuts down. You go, I don't have any extra blood, no extra oxygen for the stomach. Shuts it down. Well, if there's food in there in the middle of digesting, then you're going to get nauseated. Your patient may very commonly vomit. Also, pain in the epigastric area. That's going to be right up here around the stomach. So it may be pain, but oftentimes they just feel real yucky, indigestion pain. Sweating or diaphoresis. I read a study 2 or 3 years ago that said that's probably the most consistent thing they find is the patient is diaphoretic. We become diaphoretic very quickly in the process. When cardiac output is reduced, diaphoresis is usually right behind it. So if your patient is sweaty and it's not hot and humid, they're diaphoretic. Expect that there's something wrong. They may or may not have an abnormal pulse. It may be irregular, it may be weak, it may be fast, it may be slow. So you can't just tie it and say, well, their pulse was whatever. If you're scared, you're going to be tachycardic. If you become bradycardic in the presence of these things going on, that really scares me. Abnormal blood pressure. It could be very low because of reduced cardiac output. More commonly, I would expect to see that, but you may have people that are hypertensive anyway, and hypertension can lead to heart attack. Okay, so when you're doing your assessment on your potential cardiac patient, you're going to start with your primary assessment, right? You're going to do your scene size up. Remember those sheets? You do all of your scene size up. You're going to do your general impression. What else is in that segment? General impression, chief complaint, mental status. That's right. Don't forget those. It's important. And then beyond that, we've got our ABCs, right? And A is what? Is the airway clear? Also, well, then airway, and then B is breathing. Are they breathing adequately or inadequately? And then if, whatever their state is, if they're a cardiac patient, how are we going to manage the B part here? Oxygen. We're going to provide oxygen. If they're a cardiac patient, probably going to give it via non-rebreather. Okay, and then the C part is what? Circulation. So we'll check what? Their
You're going down to the top.
yeah, their pulse, skin signs, yeah. Yeah, all their skin signs. What does it feel like? What does it look like? And what else are we going to do for them? We're going to treat them for shock, absolutely. And then part of that is we're going to look for any external bleeding. That's what we do with our trauma patients. Can you think of a time where you might have a medical patient that you're worried about some type of bleeding that you might be able to see that's non-traumatic? Yeah, if they had stomach ulcers and they're throwing up blood, or if they have a GI bleed, so yeah, there are other things. So your primary assessment is going to be your ABCs, and you're going to manage anything that you find in there, right? It's important that you get a good history here with all of your medical patients, and we're going to start medical assessment tomorrow night. With all of your medical patients, history is going to be the key. You're going to do an assessment, but your history is going to tell you much, much more about your patient. If you have a patient that tells you they just don't feel right, they feel kind of nauseated, and you check their pulse, and their pulse is really slow, the blood pressure is low, what type of history might be important? Yeah, do you have a history of low blood pressure? Here I'm looking for, have you ever had a heart attack? You know, do you have cardiac problems? That kind of thing. So history, if they say they've got cardiac history and they've got any kind of sign or symptom that may fall into a cardiac category, you're going to treat them for the worst and hope for the best. It's never going to be wrong if you treat somebody with just a simple fainting episode like they're having a heart problem, because it may turn out they have a heart problem. We may not be able to diagnose that in the field. Now, if you think they're having a heart attack, what would be an important part of your physical exam? You can't examine their heart. Let me look at that thing. What's going to be your physical exam? Well, I'll be looking to see if they're diaphoretic, of course. That would be a sign. When we talk about a physical exam, we're talking about something hands-on. Do what? Well, we're going to feel their pulse, of course, to see if it's regular or irregular. What else are we looking for when we're feeling for the pulse? Is it strong or is it weak? Certainly. And then is it fast? Is it slow? Yeah, that kind of thing. So it's a physical exam of somebody that might be a cardiac patient. What did I tell you? One of the things you always want to look for when we were looking at respiratory problems. Remember we talked about that last day? Well, of course, we're going to assess their breathing as part of the B, pretty much. Physical exam. Do what? As part of their respiratory, yeah. We'll do that. We'll determine if they're adequate or inadequate. What are some physical things that I told you you're going to want to be sure and look for, check for? We've done skin signs, huh? Well, part of it you might, grab them and say, take a deep breath for me. But when you're specifically looking for the mechanical functioning of the heart, Do what? Well, I am going to listen to their lungs. Y'all are going, where's she going? Okay, say I listen to their lungs and I hear rales and bronchi in there. I suspect pulmonary edema in there. What did I tell you that might lead you cardiac-wise? Maybe they have some fluid buildup in the lungs because of what? Yeah, why does it back up in the lungs? Yeah, left ventricular failure. If it can't pump it out, it's got to back up somewhere. So it backs up into the left atrium where it backs up into the lungs, right? Okay, so with that little bit of information, you're doing your physical assessment of your patient. We've auscultated the lungs. What else are you going to look for that may give you a clue about the workings of the heart? Yeah. Yeah, you're going to look at the feet. Do they have any pedal edema? If the ankles are out like this, what are we looking for? Yeah, we may have right-sided heart failure, but we might have right-sided heart failure secondary, which means as a result of left-sided heart failure. So your cardiac patients, or anybody that has any cardiac symptoms at all, first thing I want to do is look at their feet. It's easy to do. That's going to be part of your physical exam. Do what? Would it show up on the EKG? Well, it could, but as an EMT, you're going to be using AD. Yeah. And then only if you know how to read it. If you know how to read a 12 lead. It would just show you left or right ventricular issues there. Yes. Use OPQRST to get a history of present illness. Remember, we're getting two types of history, right? History of present illness and past pertinent history. That's right. Pertinent past history and then history of present illness. So those are two parallel things that you want to get. If the patient says they have chest pain, you're going to go down OPQRST to get the history of present illness, but part of your sample history is going to be, your past medical history, pertinent past medical history. So with your medical patients, you're doing this most of the time. You're asking a million questions. Then you're going to take your baseline vitals. History is more important than your vitals. History of present illness, past medical history is more important than vital signs. Now, hopefully you're going to have a partner. You both come in. One can get your vital signs, but the other one's getting history. If something has to wait, you're going to wait on vital signs so you can get your history. That's going to tell you how bad your patient is. You can have a patient with normal vital signs and they keel over right in front of you and have a heart attack. So vital signs are important. Okay, treatment of a patient with possible cardiac compromise. First thing you may end up doing is putting them in a position of comfort. If you look down and you see their ankles are swollen, you hear fluid sounds in their lungs and they're laying down, even propped up under a pillow or two, you want to sit them up. They're going to breathe better if they're in an upright position most commonly. You're going to put them on oxygen. This is part of your ABCs. When you're handling breathing, body position is going to be important for breathing. So in some instances, a lot of patients, position may not be important, but for respiratory patients that are respiratory because of cardiac, you probably want to sit them up. Your cardiac patients are going to be rapid transport. Even though they appear to be stable, they may appear to be stable one minute and the next minute they're not. It's going to be a rapid transport, so be prepared for that. Okay, nitroglycerin. We talked about our medications that we can give for cardiac, right? What are they? Nitro, aspirin, and oxygen. And what order would you give those in? Oxygen, aspirin, and then nitro. Yeah. Well, I realized that this had nitro first. I was going to move it, then I had some other things that were going to mess the whole thing up, so I left it. So we have 3 medications. Of those, which are patient-assisted? Nitroglycerin is the only patient assisted. The patient has to have a prescription for that before you can assist them with that. The other two will be things that you have, oxygen and aspirin, right? Indications for nitro, remember from your sheets? Chest pain. If they don't have chest pain, we're not giving them nitro. They gotta have chest pain. If they have a history of cardiac problems and they have prescribed nitro, if they've got prescribed nitro, they have a history of cardiac problems. You also have to make sure you get a good set of vital signs, right? And then you're going to call med control to get permission to give the nitroglycerin. What's going to be the requirements? What are your contraindications to give a nitro? One, blood pressure. The blood pressure has to be above what? 90 systolic. And what's the other one?
No ED.
They can't have taken any ED or erectile dysfunction medications. Okay, good work. Y'all know this. Now, as far as the blood pressure for this, it may vary according to who your medical director is. I personally am more comfortable with 100. Some textbooks say 100. Some of them will say 90. So it's a range there. So I would go with 90 unless your medical director or somebody else tells you it needs to be 100. The reason for that is some people are not really good with their blood pressures, and they may get that thing off, and they may have a blood pressure of 80 and they thought they heard it at 100 or something, I don't know. So anyway, get as good a blood pressure as you can. Okay, aspirin. We give aspirin for what? Chest pain. Do we give it for pain? No. Only for cardiac chest pain. Now, in order for them to take aspirin, they need to be able to follow instructions and chew it up and swallow it. If they're unconscious, don't stick a little aspirin in their mouth, okay? They have to be able to chew it and swallow it. And notice we want them to chew it. This is not where you slam them down and follow it with water. You want them to chew it up. Even before you give aspirin, you have to call med control. The only medication that you'll have that you can use that you don't have to call med control for is what? Oxygen. Okay. Contraindications for administering aspirin, what are they? I already told you. Contraindication is what? If they're not able to chew it, yeah. That probably wouldn't be a real contraindication here, but what are we looking for? Yeah, outside of that one. Yeah, that's the same one. He's unconscious, can't swallow. Yeah, if they've got a GI bleed, active GI bleed, we don't want to give it to them. If they have an allergy to aspirin, there's one other one I told you. You should remember. If they're on certain anticoagulants, you want to check with that. There's one more, Toby. Good job.
Stomach irritation?
Well, I said stomach irritation. Yeah, GI, that kind of thing. I told you last time it wasn't in your textbook, but it's in some textbooks, and they found that there is a relationship there, so I gave it to you. Asthma patients. So you want to see if they possibly have if they're an asthma patient, you want to ask them if they have a sensitivity to aspirin. Good job, guys. Okay, I have a star here, so let's see. You ready? See what it is. Yes, I'm ready. You ready? Which would be a contraindication for nitroglycerin administration? Best answer. Oh, food. Thought I took the countdown timer off. Okay, who picked took one nitro pill? We actually give up to you did that one? You didn't really have to tell me. Somebody else, you weren't the only one. We can give up to 3 nitroglycerin pills, provided the blood pressure stays good. Yeah, 90 is like right on that line there. If they have a 90, I'm not giving it. So it has to be above 90.
What if you scare them and then it goes up and you give it to them?
Do you want to work a cardiac arrest? You know, that's really the bottom line here.
It's the job.
Okay, causes of cardiac conditions. Let's see. Did we get that on the recording? I don't know who that was. Caleb's going, that wasn't me. Yeah, I knew I thought so. Whoops. Cause of cardiac conditions, there are a lot of different things. Let's look at them. Coronary artery disease. Now, coronary artery is specific, right? Coronary arteries. What are the coronary arteries? It provides blood to the heart muscle itself. Okay, what happens with coronary artery disease, you may have a state where the arteries actually become clogged with cholesterol and other gunk in there, which blocks the arteries. It narrows the space. Yeah, I already said that. Good. All right. Two terms, well, three actually, but two definitions you need to know. Arterial sclerosis means hardening of the arteries. Atherosclerosis is plaque buildup in the arteries. These are two different things. Remember when we were talking about the difference between emphysema and chronic bronchitis? Remember, one of them, the alveoli actually lost their shape and they became flattened and lost their surface area. It's kind of like that. Hardening of the arteries, they are not able to ebb and flow. They're not able to constrict and expand. So they just stay static and they're not able to move. Atherosclerosis, they just have a buildup of stuff inside the arteries, which then is going to make the diameter smaller. If the diameter is smaller, what's that going to do to the pressure moving through it? It's going to increase it, right? It's just like a hose. Okay, y'all ready? You got your little beepers? What do you call them? Clickers? Those of you that are not writing. Do y'all go back and look at these on the website? For real? Okay. Y'all just like trying to make me feel better. She's saying that. You're gonna look at this one. Okay. A clot that travels is called. I told you guys this the other day. Let's see what you remember. One more, come on. Somebody. Who's not playing? I'm not waiting. Whoa. This is. Holy cow. Just confuses me. I'm not sure what the answer is anymore now. Who picked B? That's pretty funny. Okay, let's see. Embolisms, an emboli move. An embolism moves. It's like a clot, or it could be a thing, it could be a little fat glob.
So
It moves.
Can be anything. I was thinking of the air, but now I know the air.
No, don't feel dumb. Oh, when you're talking about a pulmonary embolism, that's just something that gets caught in the lungs.
Embolism can be anything.
Yeah, yeah. Like in the advanced class, we teach the students how to start IV. And one of the things that's always scary to me is there's a little needle inside this catheter, a little stylet. And if they're bringing it in and out, and I think we're gonna do this tomorrow night, hopefully. If they bring it out, they may actually shave off a little piece of that plastic catheter, very small, and it actually can get in the bloodstream and then move throughout the body. It would be, that little piece of plastic would be an embolism. And then, based on where it lands, you've killed your patient, and they cut them open, they're going to see that little piece of plastic, and they're going to go, you did that. What's your question?
Isn't a thrombus a clot too?
It is,
Oh.
but it would be blood-based. A thrombus would be a blood clot. But it doesn't, if it's moving, it would be a thromboembolism.
Oh.
It would be a blood clot that moves. That's a good question. This is where we're learning. Of course, we know pulmonary embolism would be something that's lodged in the lungs somewhere. Well, that's just very interesting. learned something here, right? What do y'all like? Did I spell something wrong? Not anymore. It moved there and stopped. It didn't start there. Coronary artery disease, thrombus, it's a blood clot, will occlude the blood flow. What happens oftentimes with a thrombus, you'll get a few little cells, like little platelets, that'll get caught on a ragged area of cholesterol or whatever is building up inside the vessel. And it'll get caught there. And consequently, it kind of breaks apart and it'll start making a clot. So it'll form that clot there. It's not a moving clot, but it forms inside the artery somewhere. Now, the thrombus can break loose. You know, it started to form there, and if the pressure goes up, the blood pressure goes up, it may actually break that little thrombus off and send it moving, in which case it becomes an embolism. It can then go to the lungs and be a pulmonary embolism. It can go to the brain, whatever. An embolus can move to occlude the flow of blood downstream in a smaller artery. Words you need to know. Okay, we're just going to talk very briefly about the way a clot forms. It's much more complex than we make it look here. But platelets, as platelets break apart, they're going to release thrombin, which causes that clot to start to form. And then as that forms, fibrin moves in and forms. And fibrin is like little hairy things. It's kind of like a spider web, if you will. You know, a spider puts all those little strands out. Well, fibrin are little strands that go together to help the clot remain and get stronger. And this is important because some other vocabulary that we're going to get to. Do I have that up here next? No, don't want me to forget. Just some pictures here about the way a thrombus is created. In just a normal vessel, you can see all the layers here. You don't need to know all the layers. But also plaque and cholesterol builds up inside the vessel here, and it makes it smaller and smaller, which is going to increase the pressure. But you can't really tell it here, but these little edges are not smooth. They're kind of jagged, and that's where your little platelets will catch. And here you can see where the clot is formed. And as the clot forms, it takes up space, and it decreases the diameter here, which then increases the pressure around that, which increases the chance that it's going to break off. A coronary artery disease is just going to be the result of reduced blood flow to the heart.
Besides eating healthy and exercise, what are the other ways to help it?
Oh, you don't need to be taking aspirin.
A lot of doctors recommend you to do that.
At your age?
Or just in general, like adult.
I would want to make sure that my doctor told me specifically to do that. Just because they say everybody should take aspirin, maybe you should talk with your doctor before you do that. But yeah, I mean, a lot of cardiac problems is genetic. You know, if your parents have bad, coronary problems, you're probably going to have a problem. But how you manage it is going to be the big deal. You eating right, you're exercising, keep your weight down, your blood pressure down. I already said chest pain is the most common symptom of a reduced blood flow to the heart. If it's not getting enough oxygen, it becomes ischemic. When it becomes ischemic, it starts to hurt. It starts screaming, feed me, feed me. Sounded bad, didn't it? Aneurysm. Y'all all have heard of aneurysms, right? Well, we have two things here. We have just an aneurysm here where it's a ballooning, where, if you look at these layers here, they kind of weaken over time with high blood pressure. Hypertension will cause the weakening of the vessel, and it'll thin, and it's just not strong like it should be. It's interesting. And it becomes weakened, and it starts to dilate. It kind of forms this little hump here where the blood is filling that. And at some point, it may burst. You have a blowout. These are not good. Where do we most commonly see these, or where are you familiar with them? We hear about them a lot in the brain. Yeah, this would be an aneurysm. We also see them in other things, which we'll look at here in just a minute. So here you've got the ballooning. So nothing major is happening here. some people may have an aneurysm for years or their whole lives and not even be aware of it. And then just one day it just bursts. Sometimes they recognize it, they see it, and then they watch it until it looks like it's starting to grow, then they'll go in. I don't know how they make the decision about the ones they're going to go in and get or not, but that's an aneurysm. We'll talk about strokes here, I think, in the next chapter. Aortic aneurysm, we know where the aorta is, right? It's under a lot of pressure, isn't it? That's going to be getting that blood that's coming directly from the left ventricle. So it's very strong. The aorta is the thickest, strongest vessel that we have in the body, and it's under a whole lot of pressure. So if you've got an aortic aneurysm, you're just getting a weak area of the vessel that's going to start expanding and ballooning out. I said that, yeah. If an aneurysm ruptures, of course depending on where it is, but if an aneurysm ruptures, it's never good. Because all that is an arterial bleed somewhere in the body. If the aorta ruptures, that's a super big deal, right? Then if I get a rupture in, some artery in my foot, right? But this close to the heart, if the aorta ruptures, it's never good. It's usually fatal. It's not a good thing. Now, if you have a rupture in the aorta in the abdomen, then we call that a AAA. And those can be very bad too. So in a minute we're going to be looking at the difference between a aneurysm that ruptures and a dissection. I think that's up next here. With an aortic aneurysm, more times than not the patient's going to report severe back pain. Oftentimes they don't feel it until the aneurysm balloons and gets much larger, and then you start feeling that. The vessel itself is not painful. You don't feel that in that vessel. But once it gets large enough that it starts putting pressure on the structures around it, then you're going to feel that pain. But usually they don't feel that pain until just before it ruptures. Usually you can't feel the aorta on physical examination. When you're palpating, you can't feel the aorta. The only time you're going to be able to feel the aorta is in the abdomen and just before it ruptures. So we talk about palpating a pulsating mass. So if they say that they have pain, oftentimes they'll say it's around the flank. It may feel like the left side of the body. It may be in the back. But if you're palpating, which you should do as part of your physical exam, you may palpate a pulsating mass. You may be able to look, if you've taken the shirt off, you may be able to look and actually see it pulsating. That's kind of creepy. That's an aortic aneurysm. A AAA, in the abdomen we're calling AAA. It's an abdominal aortic aneurysm. If the patient is large, you're probably not going to be able to detect that. You won't be able to palpate it. You won't be able to see it. Okay, the next one I mentioned was the aortic dissection. The dissection most commonly occurs in the thorax, in the upper body, in the aorta as it's exiting the heart. And what happens with a dissection is this first layer here actually tears and blood starts going through there. And it'll get bigger and bigger and bigger. And at some point, the blood will be flowing between the layers instead of through the interior. That's an aortic dissection. And it actually feels much the same pain as you're going to have from an aneurysm. A tear in the inner lining of the aorta, blood enters the opening and causes separation of the layers of the aortic wall. Oh, I said that. The pain is usually most severe when the dissection first occurs, when it separates. Now these patients with the dissection, they'll oftentimes term it as a sharp pain. They'll describe it as sharp rather than that dull pain. They'll say it feels ripping or tearing or burning, but tearing is the adjective that they most commonly use when they describe a dissection. It feels like it's tearing. And as I mentioned, let's say it's a back, flank, sometimes in the arm area, but it's extremely painful. It's very acute. Very acute. That sounds redundant, doesn't it? Syncope may be the only sign in some patients. What's syncope? Yes, syncope is fainting, so they may faint. Yeah, you get that, you get syncope a lot. Aortic dissection may present like just about any cardiac problem that you could have. It may present like a heart attack. Now you know that an aortic dissection is not a heart attack, right? Because it doesn't have anything to do with the heart muscle. But because of this, it can lead to problems with the heart. It may also cause signs and symptoms similar to a stroke. So one thing about cardiac, it can present as a lot of different things. There's so many different symptoms associated with it. How do we do it? Y'all want to take a short break? Huh? That would be yes? Yeah, let's take a short, we're probably, I can't tell how many we are. Y'all take a short break, run out, because it's, 10 till 8. Don't have to go and eat. Now's not a good time to eat. We'll be here all night.
We'll be here all night.
If everybody runs out to eat, we will be. I hope we're not going to be here all night.
It's a sleepover.
A sleepover.
I have a question. That happened the other day, y'all want to take me out. Every day since then, I've had a headache. And I can't.
I would go to it down there.
Okay. You're going to be online.
It's like they knew I like hazelnut.